And today we have the session immunotherapy, non-small cell lung cancer, and this first part is going to be in localized disease. For this, we also have the wonderful panel, and the first one is which patient need more than neo and how to personalize it. And for this, Patrick Forde from Trinity College Dublin, recently here, previous United States. Welcome, Patrick.
So thank you very much, Delvis and Charo, and thank you very much for the invitation. It's a beautiful island and great to be here. And a much shorter trip than from the US, so that's handy. So the title was, which patients need more treatment after neoadjuvant chemoimmunotherapy? And this is something that I think comes up in clinic quite a bit when we see patients. So when I see them initially, I talk, well, maybe we're talking about 3 months of therapy, maybe we're talking about over a year of therapy, depending on how the situation goes. And that could be hard for patients to comprehend in some ways, but I recommend they take it step by step, and we take it step by step and reassess at each point. These are my disclosures. So there are two, I would say, preferred treatment options for stage 2 and 3 lung cancer at the moment that can be removed by surgery. You could put adjuvant therapy in here. I think the guidelines are starting to shift a little bit more towards neoadjuvant or perioperative treatment. So that's why I've said preferred. Neoadjuvant therapy with chemoimmunotherapy for 9 weeks prior to surgery with no further planned treatment after surgery. So the patient is finished in roughly 3-4 months. Perioperative treatment, which is 12 weeks of neoadjuvant chemoimmunotherapy followed by surgery. And then depending on the protocol, post-operative immunotherapy for between 39 and 52 weeks. And it's unclear which is the best approach at the moment. When we compare the populations from the trials, we only have one neoadjuvant-only trial, and I suspect we will probably have only one neoadjuvant-only trial for quite some time. The populations were quite similar, really, between these studies. 2/3 of patients in each of them had stage 3 disease. Approximately 50% or a bit more in some of the perioperative trials had PD-L1 positive disease. One difference you do note is there were quite a lot of differences between cisplatin use, quite high rates of cisplatin use in CheckMate 816 and Keynote 671, much lower in 77T and Aegean. And one key difference, I think, as well, is that Aegean mandated patients did not require a pneumonectomy up front. So when we compare the results, it's probably a lower risk population in that study compared to the others. However, when you look at the initial results, and we have 2-year data now on nearly all of these trials, the 2-year data don't really give us a good answer. If anything, they probably lean towards the shorter course of treatment. 2-year event-free survival in CheckMate 816 is 65%, and in all of the other studies, it comes in at that level or a little bit lower. Now, cross-trial comparisons, we're told, shouldn't be done, but we don't really have a choice in this situation. So based on these data, you might say 9 weeks of therapy is enough for everyone, but I think there are some patients who potentially derive benefit from longer courses. We did this analysis, which was controversial, let's just say, and I presented it at the World Conference on Lung Cancer. This was an individual patient-level analysis of the only neoadjuvant trial, CheckMate 816, and the neoadjuvant and post-operative study, CheckMate 77T. So both of those studies involve nivolumab therapy. Relatively minor differences in the patient population. So the idea here was to try and give some answers as to which patients may derive benefit. One of the differences here, patients were included from CheckMate 816, provided they had definitive surgery. Patients in 77T were only included in the primary analysis if they got at least 1 dose of adjuvant therapy. So perhaps some issues there with bias. So here we see, and who are the patients who got a dose of adjuvant therapy in 77T or did not get a dose. So if you look at the withdrawal reasons post-operatively in 77T, so approximately half of the patients withdrew from the adjuvant portion because of toxicity. Some of the patients withdrew consent from the study, perhaps also because of toxicity. And there were other reasons for some withdrawals, including disease progression. In any case, for the primary analysis, we used propensity score weighting. using two different methodologies to match patients from the two trials to try and get similar populations from 77T and H16. And the duration of follow-up selected was quite similar between the two trials. Primary endpoint being event-free survival, landmarked from the time of surgery. So when we talk about the primary endpoints of the actual clinical trials, so event-free survival is landmarked from the time of randomization. Here we're talking about event-free survival from the time of definitive surgery, which is a later time point. These were the characteristics of the unweighted populations, and remarkably, they're quite similar even without weighting. The main difference was Checkmate H16 enrolled a lot more patients from Asia. So that weighting did adjust particularly for between nationality or between Europe, North America, and Asia. And this was the primary result of this analysis. So in one of the weighting methodologies, the hazard ratio favored perioperative treatment, 0.61. Using a different weighting methodology, very similar. And even in the unweighted analysis, if you compared perioperative treatment versus neoadjuvant only, it favored the perioperative approach. That criticism I mentioned earlier, where you're selecting some patients from 77T because they have to be able to get the adjuvant dose. So if you don't use that criterion and just compare the populations from the time of surgery, there is still a trend, perhaps favoring perioperative, hazard ratio 0.82, you'll see in the red box, but not as significant or not as strong in the weighted methodology. So which patients might benefit most from the adjuvant portion? By stage, it didn't appear to make a difference. So the trend was favoring perioperative treatment in both stage 1B and 2, and also stage 3 disease. By PD-L1 status, however, you do start to see a difference. And patients with PD-L1 positive lung cancers seem to derive a lot of benefit from neoadjuvant only therapy. So you'll see on the right of the screen here, the hazard ratio is perhaps less than 1, but very marginal, and the curves are quite close together, whereas in PD-L1 negative disease, and this is perhaps why in Europe, the European Medicines Agency has not approved Checkmate H16 for PD-L1 negative disease, there is a difference here with a hazard ratio of 0.51 favoring the perioperative approach in that patient population. Again, when we look at pathologic complete response rate, we also know that patients who have a pathologic complete response are likely to do very well. We have 4-year data from Checkmate H16 suggesting close to 100% 4-year survival. And here you'll see on the left of the screen, though the hazard ratio for those patients with the PCR theoretically trends towards favoring perioperative treatment, the curves are almost inseparable. Whereas in the no PCR group, who are a higher risk population, there is a separation, and we see it quite clearly there. So perhaps this is another group for whom perioperative treatment might be helpful. So who are the patients based on clinical characteristics who may derive most benefit? So I think those patients who have the best prognosis, those patients who have a PCR, who have PD-L1 positive disease, have less absolute and perhaps relative benefit from adjuvant immunotherapy after neoadjuvant therapy. What are other possible metrics? We now have 4-year data from Checkmate H16, and among those patients who cleared ctDNA during the neoadjuvant portion, just over 85% of them are alive at 4 years, versus 50% of those who did not clear ctDNA. Now that's an additional possible metric you could add to PD-L1 status, PCR, and perhaps ctDNA clearance during that neoadjuvant portion. And what are some other possible metrics? Well, we do know, or it's emerging at least, that there are some molecular characteristics which can predict poorer outcome with neoadjuvant therapy. Sam Rosner just published this paper in Clinical Cancer Research, which looked at our experience with all of our neoadjuvant treated patients at Hopkins and Memorial Sloan Kettering, and essentially showed that those patients who appeared to have KRAS and STK11 alterations, in particular, appear to have a much lower event-free survival with neoadjuvant-only therapy. Now, whether the adjuvant portion will actually add anything to that, or particularly adjuvant PD-1 therapy is going to improve that, is open to debate. But neoadjuvant only for these patients doesn't appear to be enough. And indeed, there are also larger experiences suggesting that KRAS-mutated tumors without the STK11 alterations do quite well with neoadjuvant only. So this is one group for whom perhaps we should be focusing trials. However, on the other hand, for some patients, there's a real practical reason why we don't necessarily want to give further treatment. So this is a 4-year analysis from Checkmate 816, and when you look at overall survival compared to lung cancer-specific survival, so approximately 8% of patients had passed away by 4 years from non-lung cancer causes. And that's important to keep in mind with this patient population, usually median age of 70. Even if the patient is fit at the time of enrollment on a clinical trial or getting neoadjuvant treatment, will they be fit 4 years down the line or 5 years down the line to show the long-term benefit from prolonged perioperative treatment? So who do I think should strongly consider adjuvant immunotherapy after neoadjuvant treatment? Patients who have PD-L1 negative disease, particularly those patients who do not have a pathologic complete response. Those patients who have higher stage disease. So even though patients with stage 3 lung cancer derive a lot of benefit from perioperative treatment, their absolute survival is still lower than those patients with stage 1 and 2. And those are, so I think if we're going to think of intensifying treatment, those are the patients for whom we should think of doing it. And if we do have a clinically available assay, which can assess ctDNA clearance during neoadjuvant therapy or even postoperatively as well, it could be a case where when you're on the brink of deciding between postoperative treatment or not, it could be a good option. And finally, there are several trials being activated in this setting, including the Adopt Lung trial here in Europe, which we hope will be open in many countries very soon. So thank you very much, and I'm happy to take any questions.
Thanks, Howard.
Thank you.